Hello, Voices of the Bench community. My name is Tanya Little, and I'm a denturist from beautiful Vancouver, Canada. I would like to invite you to a special webinar that I'm hosting with Ivoclar and LMT on Wednesday, May 7th, titled Thoughts from a Denturist, Creating Dentures with Ivoclar for 20 Years. In this program, I will review the incredible history of removables with Ivoclar and focus on the new and exciting Ivotion base print resin and, of course, the PM7. My goal is to provide you with several key takeaways that will allow you to work smarter and not harder. You can join me on May 7th by registering at lmtmag.com/webinars. That's lmtmag.com/webinars, and look for my course. I'm really looking forward to it.
Welcome to Voices from the Bench, a dental laboratory podcast. Send us an email at info@voicesfromthebench.com and follow us on Facebook and Instagram. Greetings and welcome to episode 371 of Voices from the Bench. My name is Elvis.
My name's Barbara. Good morning.
Good morning, Barbara. How are you?
I'm fantastic.
Yeah?
Yeah, you know, we always talk about the weather and this and that. It's Saturday morning. It's freaking beautiful in Florida, and I'm going to go for a run.
Yep.
So there you have it.
Yep, the day after my birthday, I am also going to go for a run.
I know. I saw everybody wishing you happy birthdays. How was it?
Pretty nice. Nothing too crazy. Still worked, you know.
Yeah.
Got to do what you got to
course.
do. Went and visited a patient that was having trouble with his denture and went ahead and fixed it for the old man because I felt bad. He was going to go the weekend without it, so
Aww.
I thought I'd patch it up, make his day, and made my day. You know, it's the little things.
Yes, I do. Agree. That's awesome.
But you only turn 27 once in a lifetime,
yeah.
so.
And forever.
It's a podcast. Nobody can tell.
You know it. That's right.
So just a quick reminder, we announced it last week, but for those looking for some great dental education or just to be among some other cool dental people, I and baby Barb, hopefully, will be at the FDLA show in Orlando, Florida from June 13th to the 14th. And of course, all thanks to the wonderful people that brought you Mio and probably some other things, Jensen Dental.
I love Mio. You know I do.
Yeah, you still deep into the Mio?
Very, very, very much. Yep.
You don't use anything else anymore, do you?
Nope, not to glaze.
Yeah,
you know it.
So we'll be set up recording anyone willing to sit down, but I was looking over that program they have, and there's some amazing past podcast guests that's going to be there that we always love to promote. So John Wilson, Alexander Wuche, Pat Kuhn, Gary Morgan, John Madden, and of course some other people that are going to be speaking.
Yeah, they always have an amazing show.
Yeah.
Sincerely, great lineup, guys.
They do a great job every time. So head over to fdla.net and join us in sunny Florida. And Barb will be coming back from not so sunny Chicago.
Yep.
You know, I don't get down there very often, but of course you leave the time I get there.
Right.
Kind of suspicious. So this week, Barb and I had the extreme pleasure of having a great conversation with two pioneers in removables that are also starting to be pioneers in digital dentures.
Love it.
Yeah. Welcoming back to the podcast is Robert Kreyer, who has been involved with digital dentures since the very early days and possibly was one of the first people to ever see a fully digital fabricated denture.
Oh, I bet he was, for sure.
And joining him is a leader in removables in the clinical space, but also a big advocate for digital dentures, Dr. Stephen Wagner. Have you ever heard of the Wagner tray? The impression tray Wagner?
Myself, personally, no.
I've actually heard this a few times, and I had no idea it came from this Wagner. And he never even brings it up. I'm like,
that's pretty sweet.
You have a famous impression tray named after you, and you don't even talk about it? I was like,
he's
so
moving
weird.
on to bigger things, I
He
guess.
is.
That's old
Yeah,
school.
he's not using those things very often anymore.
No.
Together, they tell the tale of how digital dentures have evolved, the importance of knowing and using the fundamentals of removables, and how the ultimate goal of a digital denture needs to be a better denture and not a faster denture.
So true.
So join us as we chat with Robert Kreyer and Dr. Stephen Wagner.
Are you a dental lab in need of more talent to improve your bottom line and keep production on schedule? Are you a dental tech with great skills but feel you're being limited at your current lab? Well, the answer is here. Hi, I'm Mark from Win-Win Go, and this is precisely why Win-Win Go was created. The dental lab and dental tech community needed a place where labs and technicians can meet, talk about their needs, and connect in ways that foster a win-win outcome. As a tech, if you're ready to make a change, thinking about moving in the next year, or just curious what's out there, sign up today. It's totally free. As a lab, you might be feeling the frustration of paying the big employment sites so much and getting so few tech candidates. We understand. They don't much care about our industry. WinWinGo.com is simply the best place for lab techs and lab owners to actively engage in creating their ideal future. WinWinGo.com. How dental techs find paradise.
Voices from the Bench. The interview. So here's a treat for everybody because Barb and I are excited to welcome back to the podcast. I like to call you the smartest man in dentistry.
Yeah.
I only say this because even when I post memes and I'm trying to make a joke, you come in with some facts.
That's not Rob. Come on.
Yeah,
Robert Kreyer, welcome back, sir.
Well, thank you. Great to be back.
Yeah, I think last time you were on, you were with your wife. I
think you said it was
Correct.
6 years ago.
I think it is 6 years. Have you done anything since?
Oh, we've done a few things.
Okay, good.
Since then.
Staying busy. But you come on with a friend and a doctor, Dr. Stephen Wagner. How are you, sir?
I really could not be better. Thank you for having me on.
Awesome.
Oh, we love the enthusiasm.
It's a thrill to do anything with Rob. We've worked together for a long time, and he's leading the way into a huge future, brilliant future for digitally fabricated dentures. So I'm sticking with him.
Nice.
Rob, you've been around since the beginning of digital dentures, haven't you?
Yes.
I remember talking to you about 6 years ago.
Oh, yeah.
Yeah, I think it's the first time I really got exposed to it. It was in 2009. I was given a course for Eviclar Vivident back then in Sarasota, and prosthodontist Steve Schmidt came to our course. Frank Lacello and I were teaching, and wanted to show us this denture he milled out, and it was like it opened up just gave you a vision what could be done. And Steve Schmidt was pretty much one of the true pioneers that did a proof of concept of this. After Dr. Goodacre, he wrote many articles about this, but that's when I really started thinking about data acquisition, data retention for the future of prosthetics.
Wow.
So early on it was milled, huh?
Yeah.
Correct.
Interesting.
Wow.
Yeah, and Steve can probably give you a little more insight on that. He's good friends with Dr. Schmidt, but this was very early on, and later on, I had the opportunity to be a consultant at Evident Global Dental Science.
I remember.
And
yep.
Yeah. And so that's actually when Steve and I started really working together. We knew each other from some of the prosthodontic circles,
Right.
and the ACP and APS. And I started really getting into digital dentures, being a consultant at Evident, and later on working full time for them in 2015, the end of 2015, and through 2017. Amazing experience to see all these products being developed, as well as the technology.
Yeah, I scratched my head. 2015, that was 10 years ago. It feels like digital dentures is just not that old.
Actually, it's not. As a matter of fact, Rob, I think you probably saw the first digital denture ever made because Schmidt made it. And he really combined with Charlie Goodacre, who all of us at least know the name. Charlie was doing some work with a company called eHuman. Have you ever heard of that? It's an
eHuman?
Actually.
eHuman's you should look it up. It's an educational company. They sell books, they sell apps, that kind of thing, all based around dentistry. It was a fellow, an endodontist in San Francisco that developed it. But Charlie had developed an app for training dentists to set teeth at Loma Linda Dental School, where he was the dean. And so he had a three-dimensional setup, an educational way of setting up teeth educationally with on the computer. He combined with Steve, and they were the ones that really made the first actual wearable digital denture. And I think that was maybe 2008, 2009.
Wow.
Is there still an app that can teach you to set teeth? I know a couple technicians that could use that.
There are. Actually, they have something on.
Yeah, there is.
I think eHuman has it.
Really? I kind of want to play around with it. But that was the predecessor to developing the first digital denture.
That was exactly it.
How did that first denture look, Rob? I mean...
Oh, I know. Give it up. I gotta see.
Well, it was clear base, but yeah,
okay.
The idea was that it could be done, that you could take data and then in a design and then transfer that data to mill and then create a denture. So it was rough compared to dentures today, absolutely, but it was proof of concept. It could be done.
So, Dr. Wagner, I mean, you mentioned before we started recording, and maybe you don't want to put it out there, but you've been practicing for a while.
Yeah.
Tell us your history. I mean, did you do removables from the get-go?
I did. My dad was a dentist. I'm in Albuquerque, New Mexico. My dad was a dentist, 50s and 60s. And that's when you were the best dentist in town, you were the best denture maker in town. So he came from that golden age of denture making. So I worked in his lab. He had, a little in-house lab. We made bases, all sorts of things when I was even in my teens. I got into dental school and I told myself I will never make another denture in my life. Couldn't stand it.
You liked it, eh?
I liked it. So, but it turns out I did, and I just didn't realize I liked it. And it ended up being a love. So I got out of dental school, went to a general practice residency. This was USC Dental School in California, and then Wadsworth Veterans Hospital. They call it an internship, a one-year general practice residency. And then I went down to MD Anderson Cancer Center, and I was trained as a prosthodontist doing maxillofacial prosthetics, which is really removable.
Yeah.
So I come back to Albuquerque, and I really set up myself as a removable prosthodontist and have been doing it ever since. So that was 78. For the first 20-something years, I did all my lab work myself, in the evenings.
Hold on. So are you serious? For your first 20 years, you set up everything just like your dad did?
Exactly. That's exactly
you'd
right.
Never do it?
That was a brief, immature feeling. So as I got smarter, I realized it was a great thing to do. And I mean, here I'm now 47 years later.
Wow.
I'm so excited about it. I love making them. Maybe the four of us wouldn't be bored, but if you were sitting with Rob and I, all we talk about is dentures, and we talk a lot. Yeah. And I really think this in 2025, this is the renaissance of dentistry. It's never been better than this. It's only getting better. And that's because digital technology has entered the sphere. Maybe late for removable, but boy, has it changed everything for the better. So we're good.
So give our audience, lots of dental technicians, give us your perspective on how you were acceptive of it and how did you change the way that you operate to adapt to a digital way of doing dentures, obviously along with Rob.
Well, I think that's a great question, and I think it's really the appropriate question, because we've been making dentures as a profession for 150 years, and they really weren't made that much different in 1950 as they are now. that changes. Maybe materials have changed, but we're using techniques that were developed in the 30s, 40s, and 50s, and even earlier. So I'm very traditional. I honor the past. I honor history. I was making a living making dentures, but there are limitations to the way you make a denture. One of them is that the dentures, because of polymerization shrinkage in the process of making a denture, they don't fit that well. And we had to work around that. Well, suddenly digital comes in, and a denture that was my best denture previously, same technique, but adding digital to it, they fit much, much better, made the patients much happier. The occlusion was tighter. It was just a win for everyone. So I realized that early on. And because I had to turn out dentures, every day, that's what I do. Having digital enter it really changed my way of working very quickly.
So all of a sudden you were just like, I'm in?
Yeah, no, all of a sudden I was just in. I actually, the way I got in, I'm from New Mexico. The fellow that developed Avident was born and raised in New Mexico. A fellow named Tim Thompson. He's not a dentist, but he's an engineer. Tim is actually an extremely interesting guy. He was one of the first people to bring cone beam radiography to dentistry. He was working at Los Alamos National Lab and took that technology out and was one of the first to apply it to dentistry. Then he bought a company called MTech Implants. Do you remember those?
Oh, yeah, the minis. Yep.
The mini implants. Well, he had that, sold it to 3M for a good profit, and then formed a little 3-person company, all of them engineers, 2 of them computer engineers, and they helped develop Invisalign.
Really? That's a smart guy.
You're connecting a lot of dots for me.
Well, just think of it. This one first person, CBCTs, Invisalign. Then he finished that and then opened up Avident in 2010 with that same research group. So there's real history there. And
wow.
And I was attracted to it right off the bat. I thought, this is a great idea. So anyway, that's how I got connected.
Wonderful.
And are you saying that a lot of the dentures you were doing with the CBCT? Is that the connection, or?
You know what, we could be, but I use it for diagnosis treatment planning.
Okay, sure.
You could use it to actually make digital copies of a denture.
Mm-hmm.
That can be done, but I don't do it personally. I use an intraoral scanner.
Sure.
You got to be just simple. I like the simplest way to do something. And, a lot of times everybody's dazzled by the technology that's presented, but you sort of have to keep it really basic. And that's when it works and you're happy with it.
Hey, as a lab, I like it simple too.
Yeah.
I don't need to.
Yeah,
no
got
reason
that right.
to overcomplicate it. So, Rob, when you were at Avident, is that when you met Dr. Wagner?
Like I said, we met each other before then, but that's when we actually started working together and collaborating on different ideas. And we would sit around the room and throw ideas. What can we do? And try to look at all the variables and come up with new workflows, new ways of doing things back then.
Yeah.
So
I'm sure he was giving you a lot of feedback.
Yeah. Well, what's interesting about Rob, I never told you this, Rob.
Here we go.
This is before I met you, but we were talking about dental technicians. And, as a denture maker, I've always worked with denture technicians, always had a high respect of the craft. And somebody, I can't remember who it was, but somebody said, you've got to meet Rob Kreyer. He's probably the premier denture technician, removable technician in the world. That's where you were described. And you were someplace
quite a compliment, Rob. That's awesome.
Someplace in California. So I didn't exactly know how to meet you, but somehow we crossed paths. But I had that in the back of my mind when I was shaking your hand. I'm shaking a world-class crafts person. And I never forgot that. And it was a great way for me to start with knowing you.
Oh, well, I appreciate that, Steve. Well, I was really blessed to, be involved with companies like Ivoclar, Vivadent, and Candular years ago, and be instructors for them, and really try to take the craft to another level.
Right.
So it was very nice. Thank you.
Smartest guy in dentistry.
I think he is.
So what were some of the issues you were working out in Evident? I mean, what were the early digital denture problems that both of you kind of overcame?
Probably the relationship records.
Mm-hmm.
And was probably the most. And Steve, why don't you explain how you solved this issue?
Well, I mean, this actually goes back to the beginnings. There were actually two companies that started digital dentures. One was Dentka, which is Dentka out of California, and a fellow named Ty Kim at USC Dental School, and then Avident. Those were the two, and what they both thought was that digital would allow us to make dentures faster. And they both advertised themselves from the beginning as a 2-appointment denture technique.
Yeah.
Which has turned out not to work, with exceptions.
Yeah, I was going to say, good luck with that, right?
Yeah.
Especially right away.
Some people are still advertising that.
I know.
It was the funniest thing. I started with Avident, and they send out a little kit called an AMD. I don't even remember what it stands for. Do you, Rob? AMD.
Yeah, it's a tracing device. Yeah, exactly. It's just an intraoral tracing device.
It was sort of a combination. The idea you could get all your records made and then send that to Avident and then send back a denture. Well, here I've been making dentures then, cranking them out for 20 years, maybe 30 years by that time.
Mm-hmm.
So I get my little AMD and I try to make a denture with it. You make impressions, you take intraoral scans, tracings, and then you actually, instead of setting teeth, they had a clear cellophane print of teeth that you stuck on there. I make my denture.
Wow.
And the first time I put it in, I bet my vertical dimension of occlusion was open by an inch. I couldn't get that thing closed. They looked ridiculous. I was so embarrassed for everybody.
So you're saying it wasn't simple.
It wasn't simple, and it didn't work.
And it didn't work. Yeah, that's what I'm hearing. Didn't work.
So I call up Tim Thompson. I know he's a New Mexican. I talked to the company. He said, "Well, call our president." So I call up Tim Thompson, and I tell him, I said, I'm really interested. I'm a New Mexican. We live close, but the way you are telling people to make dentures sucks. And if you
and I quote you on that.
Well, interesting. I'm quoting myself because Rob could say that's not the way I talk. That I don't use that kind of.
Yeah.
But then Tim goes, sucks. And I said, yeah, I just can't get this thing to work. And he says, well, do you have anything better? And it turns out I did. We can talk about that later, but I have a way that's turned into a device called a WTI out of Avident, which is a kind of a digital analog hybrid based on something developed in the 90s, obviously analog. So that's how I got started with Avident. But really, the whole thing there is interocclusal records are critical, and you have to have the mechanisms that allow you to do it. That I can give Rob a good record to work from, then the digital denture is perfect. If I don't, it's not going to be good.
I kind of want to talk about it now a little bit. Do you guys want to wait?
No, I want to hear about it. Obviously you're not talking about mush bites, right?
Yeah, I'm trying to get a visual of it. So they had something that they brought you that absolutely didn't work. And then you morphed into something that you created that does work. So I'm kind of fascinated on what is it?
Okay, we've made a final impression. We make it a base. Really, we make it an occlusion rim.
Mm-hmm.
But instead of having just the wax rim, I would always preset teeth on my wax rim before I saw the first patient, or the patient for the second visit. And I did that by taking a papillometer reading, which is a measurement from the incisive papilla down to the resting lip. And that's the 8-9. So it's an old technique. And so I would set up teeth 6 to 11 in wax prior to walking in and seeing the patient. And then I would actually set up some lower teeth, 22 to 27 in wax. That's what I had for appointment 2. I could then manipulate those teeth. I put them in averages, so I'd go to appointment to remove those teeth if needed to
Right.
proper aesthetics, phonetics, that kind of thing. And then I'd put the lower teeth so they're the right height, which means that when you just part the lips, you just see the incisal edge of 22 to 27. And then
the papillometer, I don't mean to interrupt you, but what is your average? So you're taking it from the papilla down to what you said, the lower lip?
Yeah. What's
your average millimeter?
Well,
just curious.
It's probably 10 to 12 millimeters. Could be longer,
okay,
depending on how much bone has been lost in the alveolus.
Okay.
Yeah.
So it varies.
So you've got a little bit of an average. Okay.
Yeah. Remember, probably in technician school, you set those front teeth at 22 millimeters from the vestibule. That was the number.
That's what. Yeah. That's what I. Yep.
But
that's exactly
but where did that number come from? Right? I don't know. It just sort of. I mean, as with all denture stuff, it's not evidence-based. It's really passed down from teacher to student.
True.
And so, but to be more accurate, if you measure from this is an edentulous patient, from the incisive papilla, and just have the patient rest their lip, and you've got a little ruler underneath it. When they rest their lip, you take that measurement. And there was a Dr. Vig in the past, I can't remember his first name, but Dr. Vig said that when the incisal edge of 8 and 9 will just barely be exposed when the upper lip is just resting, at rest, you just see a little of 8 and 9. Well, that's the measure you made, and that's where the technician would set those teeth. So that's what the papillometer is for. That goes back to the 30s, probably, right, Rob?
Wow.
Yeah, definitely.
So anyway, I got those teeth set up, and so my big thing was I wanted to do an extremely good denture, but I wanted to do it faster because time is money, and
right.
But better. We want better dentures too, not always faster.
Well, Rob's actually inferring something that's a real problem now. There's people out there on the internet, not to mention names, but they said their big thing is they gloat. They say they make a denture 2 appointments.
Oh yeah.
Well, okay. What did you say to that one fellow when he came to your lecture, Rob, and stood up?
Well, we need to make dentures better, not faster. It's more. It's for the patient. It's about making prosthetics for the patients, and however long it takes. I don't care if it takes, 3 visits, 5 visits, 10 visits, or whatever it takes to make it right. That's what it does.
Yeah, but let's hope it's not 10.
Well, you used to.
Well, there can be techniques when you have a lot of variables involved, and Steve utilized a technique called the branching, which is an old Earl Pound technique. It can take several appointments.
But the average denture that needs to be made, I mean, do you agree that we should be doing it in 3 or 4 appointments?
I do.
Yeah, I agree. If you can't, but not 2. I mean, I can see 2 if it's an immediate, and so if you have your records, you get your records from the scan or from the impressions. But for immediates, maybe a copy denture. It's a simple like a duplicate denture.
Well, yeah.
Yes. Yeah. But it's really traditionally you should have a trial denture because so many patients have aesthetic expectations. You want to make sure you're meeting those during a trial denture. And now we have the ability to let the patient take the denture for a test drive and take it home and eat with it and then show their family. And so I think that's very important to let them do that. Then that becomes a spare denture as well.
Huh.
So Rob, the way Dr. Wagner described how he set up dentures, are you saying that digitally we can achieve that just as well, if not better?
Well, no, I mean, that's a starting point where Steve's talking about with the Wagner try-in, and that's, you manually correlate if the edentulous maxillomandibular arch, you manually correlate that to 40 millimeters intervestibular, then combined with his papillometer, you have the settings for arranging the teeth, and then also utilizing the retromolar pad and, all the soft tissue anatomy for reference points for setting teeth.
Yep.
But it's 100%. The problem is right now is designers don't understand the philosophy and the concepts of denture making. They understand software, and they usually, a lot of times, whatever the software proposes, they go with.
Right.
but the software is not always correct.
Mm.
Yeah.
And so this is, I think, one of the biggest issues now is education for designers.
Mm-hmm.
Steve and I are huge proponents of bringing the past literature into the digital age, and just because there's been so much literature written on complete dentures over the last 100 years,
Right.
and it all has value today. And so we need to respect all the work that's going into that, because human beings have not changed. We're all still the same anatomy in our mouth. We just need to make better dentures for the patients. And patients, they want a better fitting denture.
So how are you bringing that knowledge to the digital age? That's fascinating. You said you and the doctor were both trying to bring that knowledge. How are you doing that? How are you helping?
Well, Steve and I both been collaborating, and Steve's has so much clinical knowledge, being a maxillofacial prosthodontist and having his specialty in denture and removal prosthetics. He's written a lot of information on clinical procedures,
Yeah.
and we're putting together this book for dentists as well as technicians.
Oh,
Another big
wow.
problem is communication with dentists.
Yeah.
How do you communicate? I gave a lecture to a large lab group. There were about 7 labs represented into this group a few weeks ago, and I asked them when I started my lecture, what are your pain points? What are the problems you see in your lab? And it
Love
was,
it. Yeah.
the three is because I wanted to, as I go through my lecture, I wanted to be able to cover that. So the 3 pain points was designs, communication with dentists, and then internal communication and training. How do you train people? There's nobody that wants to come into this field. And so those are the 3 pain points, that I think we need to concentrate on as we go forward.
I cannot agree more. I tell you what, I was on Facebook last night and there was a really long, drawn out back and forth, but basically boils down to that, is that people were not replenishing the knowledge. And you've got technicians that are just getting older and they're taking the knowledge with them. And that's just so important. And I'm so passionate about it. I know Elvis is, but man, I love to hear that. Sounds like you guys are out.
Yeah.
Obviously, the book is going to be super amazing, but and also just lecturing and trying to share all of that, because you can't take it with you.
Exactly.
To me, denture making is a craft.
Mm-hmm.
And a craft is passed on from teacher to student over time. Just like making a fine cabinet. So there are basic concepts that everyone needs to know, and they need to be able to apply them to the advantages that digital allows us. I think it's we just have to keep not an open mind, but just an enthusiastic mind that this can be done. I think people like to make dentures more than ever because they're more successful now with digital. So that's more encouraging for everybody. But it really is a communication between technician and clinician, I'm going to say. And they have to be able to work together just like we always have. And I still need to have a technician that can play the game at a pro level. You need somebody that really knows what they're doing. Digital is not going to take anything away from our skills. It's just going to be another tool for us. And that's the way to look at it.
Do you think the software makes it harder to learn the fundamentals? I mean,
No.
It kind of... Okay.
I don't. I think it makes it easier. But the fundamentals just have to be presented. That's the whole thing. If you go on YouTube, you were talking about YouTube, Barb, or
Facebook.
There is a lot of stuff on there that is just not right. A lot of people just, the idea that you can just almost push a button now and make a denture. You've probably heard people kind of imply that, and it's not. It's a tool. It's just we need accurate impressions. We need an accurate digital scan of that impression. A clinician needs a base that fits so they can take good records, not one that falls out, and we can do that now. And we need to have a final denture made with digital technology because they're going to be better. How you get there is not that much different than it was before. We can make it a little bit more efficient, much more efficient, but it's not abandoning the old. It's just adding to the old.
And then if once you understand really how to distribute the forces of an occlusion, so this is one of the big problems we see is that in design, the design will give a proposal, and sometimes the teeth are set buckled to the ridge crest, maybe out over the vestibule of some maxillary denture. And then when it occludes with the opposing arch, you get this flexure in the palate, and then eventually it'll break. So that's one thing, understanding, really how to set teeth up so the forces distribute it properly, and also for maximum stabilization, how to stabilize the mandibular denture, especially when you have an atrophic ridge, a lot of bone loss. But then, the other problem also is thickness of the denture. A lot of times you'll set these parameters, whether it be 3 millimeters, 2.75, 2.5, whatever it may be. And that doesn't mean that the end denture is that thickness in every area of the denture. So you have to do like a slice, a little analysis, thickness analysis, after the denture is designed to see this, because we're seeing that many times around the gingival margins, interdental papillas, around the peripheral borders, the dentures are much thinner than where the parameters were set. So it takes a little bit more time to do this analysis, but you end up with a better denture and a higher, successful outcome and less internal remakes.
Does it scare you both just a tiny bit, though, that the software is setting it up in some of these ways, and then we are missing the skill and the knowledge to be able to recognize those things? And there's a lot of young dentists that are getting into it that don't know what you both know, that are going into, handling these things and putting them in the mouth, and eventually they're going to fail. Like, sounds to me like that's one of your concerns, is getting that message out.
A technician needs to know how to set teeth, but with and all the concepts that go with that. But they also need to take advantage. They don't need to set up every tooth every time, day to day, denture after denture after denture. They can have the computer help do that. Kind of almost make a typodont for that patient, where those averages teeth should be. Get them set up, and then the technician can go in and creatively refine that. That's the way I look at it. It's saving time. Teeth are set up, then they go in and do the things that really require the brains to do. And so I think it's an advantage, but they can't just say, the computer did a good job and I'm happy. They need to know what's right and wrong about it, because there will be rights and wrong. So it has its advantages practically.
Understood.
Well, I think that's what a lot of people are doing, though, is taking what the software is proposing, not giving it the eye that it's needed.
Right. That's exactly right.
Yeah.
That's what I was trying to say in a nice way. So I'm a little concerned, that we need more training on some of these.
You need just as much training. We need to have core training.
Right.
They need to be trained like, a journeyman technician of old. They're no different. They just have different tools to work with.
I think the software makes it easy to people to forget that.
You're right.
Because the software, if it puts the tooth there, then it must be okay because the software did it, and that's just not right. So how are you going to fix that, Rob? We're relying on you.
I do want to know, yes. How are you going to do it?
So I think it really boils down to internal communication labs. So I've been in some labs doing some consulting, some analyzing their workflows, and interesting still in the laboratories. We kind of tend to work in silos where not a lot of communication in between teams. So I was in this one lab, for a good example is, and I was watching the denture finishing, because I always kind of like to look at the end process and work my way backwards. I was noticed that when he was finishing the digital dentures, he was extensively spending a lot of time on the borders because they're all set too long. All the peripheral borders, so he had to grind them back. And the person that was designing them did not really understand denture anatomy, denture borders. And so they overextended all the borders. But then the person finishing it was taking an extra 15 to 20 minutes to grind back all these borders. So it's just, I got the denture technician that was finishing them. I said, did you ever talk to the designer? He goes, no, he won't talk to me because I'm just a denture finisher. And, it's kind of like this prima donna thing where the ceramists used to be. Now we got the designers.
I know.
Right.
Uh-huh.
So they wouldn't talk. So I said, you guys got to talk. You have to sit down and with each other and learn from each other, because this is then you're going to save 20 minutes of denture adds up. That's a lot of labor over a period, over a day, over a week, over a month.
Yeah.
So anyways, they started communicating, worked out better. But I think it's a lot of internal communication. And then like I said earlier, you have this analysis, and it's almost like a design QC, that after the designs are done, and if they go out for a design preview to the dentist to sign off, or they come back, there needs to be somebody doing that has more knowledge, understands occlusion, understands denture anatomy, to do that design QC, and make sure that's when they would maybe do the thickness analysis or whatever, but just before they go out. I mean, the ideal thing would be to have a software you then put the designs into, some sort of a AI that really says, is this the proper design or not? Looking at all the rules, and maybe there would be something that would be ideal, but we don't have that right now. But for right now, you need the human beings with their knowledge to sit there and determine if it's a good design or not.
You mentioned a lot of things about determining if a design is good. Is it easy to determine if it's good without a try-in? You know what I'm saying? Are you just looking for the landmarks and the functionality? I guess the question is, how do you do that visually?
Well, there's certain averages you take. I know as a technician, I know what I do. Steve probably looks at it a little differently than I do, but I look at different averages. I mean, there's overall maybe 8 millimeters from the incised papilla. Look at where the teeth, that's labial to the incised papilla. Look at where the teeth are. The maxillary teeth, look where the ridge crest is, the maxillary, where the posterior teeth in relation to the ridge crest and the tuberosity.
Can you make a checklist for me?
Yeah.
Yeah, actually I do. And then it's the same with the mandibular arch. You look at the retromolar pad. The big mistake I see in a lot of designs is people setting the second molar on top of the retromolar pad.
Oh.
And so then you have this inclined plane as you're going, from the ridge crest up to the ramus in this retromolar pad area. And then if you have occlusion on that inclined plane, the mandibular denture is going to always move forward. So you want to try to achieve maximum stabilization, not set teeth on an inclined plane. I mean, there's basic things. You want teeth over the ridge.
That's a big one I noticed, that they don't set it over the ridge. You're like, what?
And these are all things that are covered, in this book as well.
How far along are you on the book?
I'm going to have it on my website by May.
Ooh.
I've got a big lecture coming up, biggest one I've ever given. I'm going to have 2 days at the CDA meeting, the California Dental Association meeting in Anaheim in May 20th. I want to be able to have that available for then. It's actually going to be a living document because it's going to grow with time.
Right.
We're gonna do it as an ebook, so that Rob and I can keep adding to it, refining it, adding videos. You can have a nice video on an ebook. It's really the 100 things you need to know to make a denture. There's a lot of little refinements that go into that. As Rob kind of alluded to, a technician looks at something a little different than a clinician. Well, we want to be able to share that with each other, and so we can work forward with it. So I'm hoping May. We've been working on it like for 50 years, it seems, but not quite. But it's one of those things that we'll have something to show you then, and it's going to. I have a website called BigJawbone.com.
Big Jawbone.
It's going to be on BigJawbone.com in May. So
nice.
That's our little plug.
I just like the fact that it's a technician and a doctor that are working together to teach both sides what they need to do and what they need to learn to be better and be successful. And I don't know if I've seen anything like that up so far.
Never. And the other thing is, an admission from the dental side. So I'm the representative of dentists here. Dentists don't really have a great knowledge of denture making. They have a poor knowledge of denture making because of the educational time given in a dental school.
Sure.
The skill comes over time.
I thought you guys blew right through that in dental school.
Well, they pretty much do, and
Yeah.
and it's not good.
I know.
It's a footnote.
Yeah.
What I say is that the accumulated knowledge of denture making, going back to 1856 and Charles Stent and Compound, all the way to today, is housed in dental technologists. I mean, that's where the knowledge base is, and as clinicians, we've got to take advantage of that.
Yeah.
And your responsibility is to be able to teach more technicians to do it, as a profession. But I think we rely on you a lot. Hopefully, I can increase the skills of the dentist. I mean, giving you a good record, giving you a good impression, things that you can work with. But a lot of it, when you give me a denture, I'm saying as Dr. Dentist, I need to rely on you that it's really is well done, because I probably don't know what to change unless I've had a lot of experience. So we need your skills.
Well, they're not going to come cheaply. No, I'm just kidding.
You pay for what you get, right?
There's also going to be a need for traditional dentures for a long time, as long as the manufacturers keep making teeth. But I really believe it's interesting when I see with digital dentures, it's creating a higher niche market for the really boutique technicians that make the really extensive labor and put it in a lot to make the characterized dentures and higher aesthetic value. So I think that will be a higher demand for that. The problem is the data. Digital dentures is not really about subtractive, additive, whatever. It's about data. It's about acquiring data, gathering data, and what do you do with that data? And then data retention over a period of time for future treatment. And if you're transitioning a patient from a complete denture, mucosal supported, to implant supported, you need that data for treatment planning, diagnosis, and then eventually design of the next prosthesis. So data is really the differentiator, I believe, in the digital dentures.
Right.
Well, what do you say to those people that say the digital denture is not as attractive as an analog denture? Not all of them need to look like the cover of an Instagram post.
Well, one thing is I think this goes to a broader spectrum. I think people now make dentures that look like dentures. In the United States, people if you have somebody pick the color of a tooth, they pick the whitest thing they can.
Yeah.
And that, and I call it urinal white.
White.
And it's not natural, and they get them set up. They're not natural. The sculpting of the teeth themselves and the naturalness is gone, and it's not being helped at all with digital. It's different in Europe. I guess they want more of a natural look in Europe than they do in the United States. Yeah. C4, right.
I was in Europe in December, traveling around a few different labs in Germany and Italy, and it's interesting. They say the A2 is now the A3, so everybody's gravitating to lighter and brighter shades.
And that's a lot for Europe.
Yeah. Yeah, exactly. Yeah, because they always used to be age appropriate,
right?
But now, it's starting to get a little bit lighter.
Yeah, we've talked to technicians from all over the world that said, for the first 20 years of their life, they never even owned a bleach shade, but now they're starting to.
Yeah, it's crazy. But what I think, especially with the techniques that Rob is developing, we're going to be able to make dentures that have teeth that differentiate, the hues and chromas of the teeth, even in an individual, will vary. Like canines are a little yellower than centrals, right?
Yeah.
Well, they'll be able to put crazed lines in, decalcifications. The gingiva, it potentially, with what Rob's doing, the gingiva can actually start looking like gingiva. Yeah.
How are you doing that?
Yeah. Is that composite on top of?
Yeah.
No, the problem, even if you do composite, that's the problem, that it's not reproducible.
Yeah.
So you want to make dentures that are reproducible for the patients.
Yeah.
I mean, a good example is, we deliver for, ever since dentures have been 150 years, 200 years, whatever, we've been delivering one denture to a patient. That patient has to wear that same denture for 3 years, 5 years, 10, 20, 30, many, many years out of
Yeah.
their life. The
Right.
same denture, same piece of plastic.
Mm-hmm.
But now, as technologies advance and we have the reproducibility factor, we can make, just with a click of the mouse, make two dentures exactly like each other. So it's I think that, but it's combined with the multi-jetting or polyjet technology that I'm
Right.
working with. And the poly is, everybody sees that, there's a number of manufacturers, major manufacturers, around the world that are now, developing this technologies as well. It is a future technology where we can go monolithically and then actually utilize voxel printing to create different, characterizations in the teeth and in the base.
Yeah.
Right.
So you're talking about printers that can change color mid-print.
No, not mid-print. You could do that mid-print, but it's just all programmed into the print cycle where you want the desired color, where on the
Wow.
base, where on the teeth, what degree of translucency you want. So as Steve was saying, current technology that we have is where you can, if you unbridge the teeth in an unbridged area, you can then click on that tooth and make it like, if you want to create a focal point, maybe the central's B1, the lateral's A2, canines A3, something like that. You can do that. You can make like the old BioBlend teeth where there was a variation of shades. So that technology is there right now. It's taking it to the next level where next year we'll be able to even have more tooth characterization and base characterization.
Wow.
I'm doing some research now. I might just mention, I think it's perfect for this topic. I'm a clinical professor down at the Woody Hunt School of Dentistry in El Paso, Texas, which is Texas Tech.
Mm-hmm.
And we're doing research where we're scanning the gingiva of dental students. We're going to do it in several different dental schools because if you go to a dental school, there's all sorts of different ethnic groups representative in the student body. And what I think is that we're finding out that the gingiva changes depending on your ancestry. For instance, people from India have many of them have darker gingiva. And it's not just one color, it's just a myriad of colors versus an American Indian that will be entirely different. What my dream is after this research is done is we'll have the data to make if you're making a denture for, let's say, somebody from the Navajo Nation, you could make that thing look like it was growing in their mouth rather than just the pink or purple or light pink. That's old school now. Wow. We're going to be able to make these dentures really look like they're breathing, they're living, and that's another thing that technology will allow us to do, and that's going to happen real soon.
And these printers
so that totally turns me on. I love that. Go ahead. Sorry, Elvis.
Yeah.
No, I was going to say these printers exist now.
Yeah. So it's the polyjet printers. It's with Stratasys. It has the J5 printer exists. Interesting about, Steve was talking earlier about traditional dentures, how we used to process and the polymerization, distortion during polymerization. So we used to get at least sometimes a millimeter, depends upon how you cure the denture and how you mix the acrylic, of deviation, space between the denture and the model. You get some lifting up in the palate. As we progress through injection molding, then we get into subtractive molding, this deviation gets less. And Brian Goodacre and Dr. Kanazawa in Japan did some studies, and I think they looked at the average deviation in digital was about 0.4 of a millimeter. So we're seeing now, with the polyjet technology, is we're getting deviation like 0.1 of a millimeter. So we're giving the patients a better fitting denture. So if you get a better fitting denture, it's more stable. This is what patients really want. And I mean, you look at denture adhesive business is $1 billion industry.
That's nuts.
You can have dentures that are, extremely strong. We used to make dentures out of gold bases, out of metal bases years ago, but you can have the strongest denture, but if it doesn't fit and they have to use adhesive,
Right.
It's not you really haven't done the patient a good service.
Yeah.
So we're finding that we get extremely much better fits. We've had patients say that they don't have to wear adhesive any longer. So I think this is really good. We can change somebody's life by taking them out of adhesive, make them a better fitting denture. We've done our job.
Mhm.
Wow.
Are you getting hate letters from the adhesive companies? You're like, hey, stop, stop trying to make these so
Eventually,
good.
eventually, I hope we get a lot of them.
So I'll just right back to when you were talking about the tissue. So I've always heard it about tooth shapes and corners and, different things that make the aesthetics different from a male, female, different personalities. But I don't think I've ever heard anybody talk about tissue being different and the colors. And that is like something I've never heard. That's so wonderful.
There's 6 choices traditionally.
But then natural gingiva has pigmentations, as Steve was saying, in different patient populations. And these pigmentations could have blacks or purples and browns
Right.
and them different degrees, and to make it look natural.
Right.
And when I used to teach this for Candelor and Ivoclar, you'd have patients say, I love my dentures, but I want another one just like it. And you could not make it exactly the same. But now with the data retention and the reproducibility factor, we can.
Wow.
So we can make 2 dentures exactly the same for the patients.
I love that point.
Dr. Wagner, do you always give your patients 2?
No, but that's actually a great point. I do offer them a second denture at a discount.
Yeah.
Because it's easy to make. When they come back in 5 years and I'm remaking a denture, I've been doing this long enough. I can take that old data from 5 years ago, print up a trial denture there, bring it in for a second appointment, make new impressions, make a little adjustments, and then make a denture. I've had a patient. I've got one patient who's a lawyer by day, and she's a biker by night.
I was going to say, and a hooker by night.
Almost, a biker. So
That's pretty close.
So she has her
no
lawyer
disrespect
teeth.
to any bikers.
I know you can edit that out.
Well, yeah, she has her lawyer teeth, and I made her a second set of teeth with a gold canine.
Oh, jeez.
And that's her biker teeth.
That's awesome.
And so
love it.
So you could do anything. And then I've had people where they want a little darker shade and one with a little lighter shade. You can do that. Certainly a spare denture for people that are on cruises. For some reason, they always lose their teeth on cruises. So people have we can make the exact same denture multiple times. And that's actually one of the biggest benefits of digital for a lot of reasons. Mm-hmm. But so that, it's done routinely. So the question is, the answer is yes. I do offer them a second set.
I got to ask this question because I'm a ceramist, but my brain goes to, like, in 5 years for an older person, what changes? Their tissue? Does it shrink more? Does their jaw change? Like, how would a fit change? Not necessarily the teeth, but what changes happen?
Tissue.
Does
bone
it
and
shrink?
tissue.
Does it?
It atrophies. It shrinks.
Okay.
And it shrinks differently in the upper than it does in the lower.
Huh. Okay.
The dentures also, they become infected with yeast and bacteria, and they don't clean them. So they need a new denture just to make it kind of a fresh denture.
Yeah. Okay.
But the big changes are tooth wear and atrophy of the tissues, or certainly modeling of the tissues that changes over time, where a reline or a rebase would help. That's the difference. That's the foundation. It makes the denture less stable.
I guess I should know that, but I don't. So I really wanted to ask you that question. That's fascinating.
Yeah.
Wow.
Yeah.
Do you think there's any movement to get insurance companies to provide more dentures quicker as we move into digital? Because I keep hearing that some insurance people can't get new dentures for like 7 years or something. But
well, the VA it's a 5 years.
5 years. Okay.
That seems to be the number. In Medicaid in New Mexico was 5 years.
Yeah.
I tell patients 7 to 10 years to change a denture.
Mm-hmm.
More because at least with the older techniques, they kind of break down and they just can't be cleaned. They're just the plastic is degraded.
Sure.
Yeah.
I don't think we're going to see that as much now, but just the idea of getting a hygienic denture in their mouth every once in a while is important.
Yeah.
But I don't know if the insurance companies will change. I mean, they're going to follow the lead. But I think at 5 years, that's not a bad.
Okay.
True.
Many insurance companies do that now. That's about right, I think.
I mean, there have been some studies lately relating cardiovascular problems to denture biofilms and plaque and dentures, and that is something that I think needs to be addressed to these insurance companies. If there is in fact a relationship,
Yeah.
then it should be sooner. But what I'm advocating is, like I said earlier, 2 dentures be delivered, one to wear and one for hygiene. And
Interesting.
and then you just switch them out, and
Right,
you always have a clean denture.
Yeah.
Yeah, I think if I had to, just because of the people I know, I'd have a new set every week, honestly.
Really?
Yeah, why not?
Just make a disposable denture.
There you go.
Well, one thing that the technician, what you can offer from a lab, instead of a rebase of a denture, which is basically keeping the teeth and replacing all the base resin, you just print a new denture.
I think we would do that with every digital denture, I would imagine. It's just easier.
Yeah, I think you're right.
For sure.
Yeah.
Mm-hmm.
Yeah, one question I had, and I gave a couple lectures in Lab Day this week, and they was about what do you do for relines and repairs. And you have the patient needs it back, you can repair it. It's not an issue. But I think we need to get, this methyl methacrylate, this monomers off the lab benches. It's not healthy for technicians.
Yeah, no
It's
doubt.
not healthy. And you walk, you walk in the lab, and what does that smell? The technicians don't know what they're doing. I don't know what smell, but and so it's not healthy. It definitely does erase your liver enzymes.
Totally.
But the residual monomer that's in these repairs, that's in these relines, is not healthy for patients either. So we need to start thinking differently, and just reprint another denture, make a refreshed denture, not a reline denture.
Mm-hmm.
Well, it should be easier just to hit reprint. It's less labor, honestly, to do a whole repair and all that. So I don't know.
Right.
I don't know. Gentlemen, that's some interesting stuff.
Yeah, loved it.
I'm excited to check out this book, actually.
Excellent.
Good.
I'll send you a copy.
Sweet.
It's all about making a better denture for the patients. Like I said, it doesn't matter the time. It's making it better.
Yeah. And it covers, obviously, the digital aspect of it.
Correct.
Yeah.
That's right.
And you two are going out on the road, I'm assuming.
Quite a bit.
Awesome. I love it. I want to know where you're going. If you're close to me, I'd like to bring some people from the lab to see you because this was really fascinating. Good stuff.
Yeah, we'd love to see you.
Awesome. Dr. Wagner, Robert Kreyer, thank you so much.
Thank you.
Well, thank you, Ellis and Barbara.
Yeah, appreciate it.
It's definitely our pleasure.
Yeah, let's keep those dentures flowing. That's where I'm leaving it.
You got it.
Thanks, everybody. Have a good one.
Thank you.
You bet.
Thank you.
Bye-bye.
A big thanks to Robert and Dr. Wagner for coming on our podcast and talking to us about what many others are not talking about when discussing digital dentures. It's easy to get caught up in the excitement of maybe possibly easier manufacturing and quicker setups, but the importance of taking your time to do it right. You got to do it right clinically, and you have to do it right in the lab, and that should always be your priority. To check out the ebook that goes over all the amazing things that they talk about and a whole lot more, head over to, I love this, bigjawbone.com.
Yeah, how many websites do you think he had to try before he landed on that one?
I don't know, but Big Jawbone, that's pretty impressive.
Yeah.
It's coming out soon, I think.
Yep.
It's not out yet, but it'll be out soon.
Stay tuned. We'll try to keep everyone updated when they do launch that ebook because it sounds like it's going to be killer.
And I must announce something personal. I could be a grandma this week.
Oh,
Any moment
crap.
now, my son and his beautiful, awesome mommy are going to have a baby.
No one's going to believe we're 27 anymore if you become a grandmother.
I know. I'm so excited.
That is excited.
So send some blessings my way.
Oh, you're going to be busy with grandma duties.
You know it.
but you'll still have time for the podcast.
Of course.
All right, everybody. That's all we got for you. And me and Grandma Barbara will talk to you next week.
Have a great week, guys.
Bye. It's like I don't talk for 3 hours after getting up, and then I have to talk to you.
That's hilarious.
The views and opinions expressed on the Voices from the Bench podcast are those of the guest and do not necessarily reflect the official policy or position of the host or Voices from the Bench, LLC.